Part 2 video on MCQs, and here you can see there's a lot of MCQs in this humerus. You can see the greater tubercle, you can see the lesser tubercle, and you can see the intertubercular sulcus here, and this is medial lip, and this is the lateral lip. This is the greater tubercle and this is the lesser tubercle. And greater tubercle, three muscles are getting inserted. Greater, so you can sit over there. S-I-T, S for supraspinatus, I for infraspinatus, and T for teres minor. And here lesser tubercle is very less small, so it is which muscle is getting inserted? Subscapularis. So this is one MCQ. And here you have the lateral lip, and here you have the medial lip. Already I have explained. Medial lip for teres major and lateral lip for teres pectoralis major. Between the two majors the lady is there, that is where latissimus dorsi in the floor. Through that one big tendon, intracapsular origin is coming here, that is your long head of biceps, and one important artery, that is anterior circumflex humeral artery. These many structures are present inside that. And then if you come down, there is a deltoid tuberosity for the insertion of deltoid, and here just opposite and medial to the insertion of deltoid you have the insertion of a small muscle coracobrachialis, which is coming from the tip of the coracoid process along with the short head of biceps. These two are sibling muscles, and this coracobrachialis is pierced by musculocutaneous nerve. After piercing this coracobrachialis, musculocutaneous comes down as lateral cutaneous nerve of forearm. If you come down here, you can see the medial epicondyle and the lateral epicondyle. Lateral epicondyle, one important event takes place where the radial nerve divides it into superficial and the deep branch. Understand? And then here, behind the medial epicondyle, you have the ulnar nerve. This ulnar nerve can be palpated. It is also called as musician's nerve. It can be palpated behind the medial epicondyle in some inflammatory conditions like leprosy, that is Hansen's disease, and it was also involved in lead poisoning. And then if you see the back, this is a surgical neck. Already I have told you, surgical neck axillary nerve along with posterior circumflex humeral artery. Here I mentioned anterior circumflex, here I am telling posterior circumflex humeral artery is here. And if you come down, radial nerve in the spiral groove, and here you have radial nerve, spiral groove. So radial nerve along with the profunda brachii artery is situated here. And the most important viva question here is the carrying angle. How much is the carrying angle of the humerus? 15 to 17 degree or 160 degrees. Both will be given in different angles. Okay. So this is because of the medial flange of trochlea. Can you see this? This entire area is trochlea. Here the medial flange of trochlea is protruded out. It forms some angulation in your between the arm and the forearm. That is called as, can you see the angulation? All of you can see. That is carrying angle. It is more in females. Next, here is the radius and ulna. Olecranon process. Olecranon process, which muscle is getting inserted? Olecranon process is at the back. So your triceps, long head of triceps is getting inserted. And here supinator, crest, and they are all not MCQs. And here is the annular ligament where the neck of the radius, important even, where the brachial artery bifurcates, very important. This area is also very important. Can you see the this is called dorsal tubercle of Lister. It is present in the radius. This is MCQ, dorsal tubercle of Lister. Extensor pollicis, longest tendon will be lying in the dorsal tubercle of Lister. And the annular ligament, can you see this? It's winding around the neck of the radius. It's inside that only you will be having the neck of the radius. Superior radial nerve joint. Supination, pronation takes place at the superior radial nerve joint, and this area is very important. All the carpal bones, each carpal bone, one important point. First we will talk about the scaphoid. Scaphoid is a bone which is more prone for avascular necrosis. She looks L. Lunate is more prone for dislocation. Trapezius, she looks too pretty. Pretty is very important, that is pisiform. Pisiform is a only sesamoid bone in here, and it gets ossified in the tendon of, in this side is ulnar side. So flexor carpi ulnaris. So pisiform, it will be gone with the, it would have gone with the flexor carpi ulnaris tendon. So pisiform is a sesamoid bone, very important. And then here trapezium, trapezoid. Trapezium, there is a groove in the trapezium. Can you see this groove? flexor carpi radialis tendon will be passing the screw. This is MCQ. And then between the lips of the screw, your flexor retinaculum is getting inserted. So you have a space in this. That's why the tendon piercing the flexor retinaculum is flexor carpi radialis. Trapezium, trapezoid, capitate is the largest carpal bone, and hamate is here where the flexor retinaculum is getting attached. These are the where the interossei, palm or interossei will be attached. 3 palm or interossei, sometimes 4, because the thumb already it has its own pollicis muscle, so usually 3 palm or interossei. The action of palm or interossei is PAD, adduction. Palmar interossei. Which digit doesn't have a palmar interossei? The middle one doesn't have a palmar interossei. It forms an axis, and then palmar interossei, that nerve supply we'll see later. And then here also this side dorsal interossei. Action is PAD, P palmar interossei, adduction. DAB, dorsal interossei, abduction. Understand? And then here, which tendon will be going in this way? Flexor digitorum superficialis. It splits and getting inserted into both sides of the, it goes here, splits and inserted into the middle phalanx. This is the middle phalanx. Through the middle, who will be going to the distal phalanx? Profundus. Flexor digitorum profundus will be going to the distal phalanx. These fellows will be split, divided into 2, and then inserted into both sides of the middle phalanx. Same thing here. Extensor tendon will be coming. It stops here and it forms a triangular expansion here, that is called extensor expansion. This extensor expansion, from the apex, a central slip will be going to the middle phalanx and 2 lateral slips will be going to the distal phalanx. Look at the difference. Flexor digitorum superficialis goes to the both sides of the middle phalanx. In between, the tendon of flexor digitorum profundus goes to the distal phalanx. That is the difference between the extensor aspect and the flexor aspect.